My name is Carrie Espinosa, and I'm the owner of Horizon Benefit Services. I jokingly call myself Medicare for my clients because, Medicare and Carrie come together, and then that gives me a sense of permission to make this stuff fun. Born and raised in Lake County, Illinois, my grandparents raised me. My grandmother is age 88 and a huge influence in my life, and a big reason of why I do what I do. I will tell you that when you have an 88-year-old parent or grandparent, if you want to torment them, when they have to be somewhere at 1 o'clock, you show up at 12:45. And I say that in jest, but on Saturday I had to take my grandma to the bank, and we got there at 1:45, and she says, "We're as good as late." I do love that about her, though, and she does definitely always keep me on time. All right, we'll get into why you're here today. I want to start with gratitude to Elderwerks for the opportunity to be an extension of the care and service that you provide to the community. I also teach the Mastering Medicare class at the local community college, and I've had the pleasure of speaking at a patient advocacy conference in Vegas for the last few years in September. So know that I'm coming to you with some knowledge on insurance, but also just healthcare, and all of that helps me better communicate and better share some of these changes that are coming in a way that makes it more tangible for you. This is a picture of my team. I'm proud to say that our mission is to revolutionize the benefits experience by providing clarity and ease to a really complicated and confusing landscape. We empower our clients to know how to choose and use their benefits. And we advise on the front end, we broker, and then we advocate on the back end for our clients. As you can see, my agency serves a couple different markets. We are a hire to retire solution, which also puts us in a unique position to really understand the whole insurance ecosystem and how it's different when you're working and different when you're 65 or older, and in between is different as well. I want to start by talking about how to prevent ANOC shock. And I don't know if anybody has ever heard of this term before, but ANOC stands for Annual Notice of Changes. Has anybody received their annual notice of change yet from the insurance company? So the annual notice of change is a document that you should be receiving now if you have not already. For anybody who has a Medicare Advantage, which is also called Part C, or Medicare Prescription Drug Plan, which is also called Part D. And that annual notice of changes, or the ANOC, will outline any changes in the plan that will be taking effect in the coming year. Yep, thank you. Yeah, I appreciate you popping up and saying, yep, your mom's received it. I do want to say something that's very important as we're going into further discussion about all of the changes, specifically in regards to the annual notice of changes document. If anybody has a Blue Cross Blue Shield Choice PDP, you will have no choice to keep it starting for 2026. Let me just clarify one more time. The Choice Prescription Drug Plan that's offered on a standalone basis with Blue Cross and Blue Shield is not going to be available in 2026. So if you have that plan and you get your annual notice of change, it should clearly indicate that that plan is not going to be an option for next year, and you should plan accordingly. Make sure you pick a new plan. All right, let's talk about some Medicare Matter stuff and have a brief review on the different ways to get Medicare. And Just to kind of go very back to basics, Medicare is that red, white, and blue card. Medicare has two parts, Part A and Part B. Medicare Part A, it says, is hospital insurance. Medicare Part B is medical insurance. I want to clarify that a little bit even further. This came from the Medicare New Guide. I want to say that Medicare Part A is inpatient hospital insurance, and B is outpatient insurance, medical insurance, because hospital can be inpatient or outpatient. So if it's inpatient, it's Part A, outpatient, Part B. But original Medicare has two parts, A and B. Medicare Part A, you typically earn based on your working quarters. Medicare Part B, you do pay a monthly premium for. The standard monthly premium in 2025 is $185 a month. That is per person. Occasionally I'll have a couple ask me, oh, well, how much is it going to be for couples? Do we get a couples discount? And I'm like, unfortunately, no, it's $185 per person. So that red, white, and blue card, Medicare A and B, is the starting point for coverage. Medicare was never intended to pay 100% of your medical bills. It was created as an offset to medical expenses and provides a basic foundation of coverage. Medicare has some gaps. It has deductibles, copayments, and coinsurance. So the big decision for consumers is, do I want to stay with my original Medicare, my A and B, fill the gaps with a Medicare supplement plan, also called Medigap, and get standalone Part D coverage? And that's that first option, sort of in the middle of the page here, that you see as an option for getting your Medicare. The alternative to that is called Medicare Advantage. And Medicare Advantage is when you have a private health insurance company manage your A, B, and sometimes or usually Part D benefits all in one plan. So Medicare Part C equals A plus B plus D. And that's when an insurance company like Aetna, Blue Cross, Cigna, Devoted, Humana, United Healthcare, one of those, and there's more, right? But one of those insurance companies manages all of your Medicare benefits, and they give you extra things like dental, vision, hearing. I jokingly say with my clients, they even wash your car on Tuesdays. I'm obviously just teasing about that. But when I was a child learning how to do algebra, and my grandpa was teaching me X's and Y's, he would say, Carrie, X's and Y's are like apples and oranges. And I want to say to everyone here that original Medicare and Medicare Advantage are like apples and oranges. So with original Medicare and a supplement and drug plan, you're going to pay your Part B monthly premium of $185 plus additional money. You're going to pay a monthly premium for your supplement and likely something for your drug plan. But for that, you're going to have very low and limited out-of-pocket costs. You can go to any doctor or hospital that takes Medicare. With Medicare Advantage, you're still going to pay your Medicare Part B premium of $185. But then you're probably going to pick up a Medicare Advantage plan that has little to no premium. Instead of having low out-of-pocket costs, though, since you're not paying a monthly premium with Medicare Advantage, you're going to pay as you go up to a maximum out-of-pocket. And there's HMO-type plans and PPO-type plans. We're going to talk just a little bit more about that in a moment. So I'm a big fan in my office of creating matrices where I can easily look at something side by side and see what the pros and cons are of each. I'm sure everybody here knows how to read, so I'm just going to hit these on a very high note. When it comes to doctors and hospitals with a Medicare supplement plan, you can choose any doctor or hospital as long as they accept Medicare patients. With a Medicare Advantage plan, you're likely going to have a network of doctors. And we'll get down to network in a minute and I'll elaborate on what that means. But a network means doctors that have agreed to accept the plan's terms and conditions. When it comes to referrals with Medicare supplement, You don't need referrals. With Medicare Advantage plans, there's HMO plans where you do need referrals. There's PPO plans where you do not need referrals to see specialists. When it comes to a network of doctors, there are no network restrictions with a Medicare supplement plan. Coverage travels with you anywhere across the U.S. When you get a supplement plan, believe it or not, it even does have some foreign travel coverage, assuming that you're looking at one of the plans with that, like a Plan G. With Medicare Advantage plans, you might have network restrictions. You might have an HMO plan where you can't cross state lines. You might have a PPO plan that's more flexible, but doctors and hospitals can be in or out of network. Emergency care is generally covered for travel within the United States and even sometimes abroad with Medicare Advantage, especially with the PPO plans. When enrolling in coverage, you have the option of choosing either of these right out of the gate. If you choose Medicare Supplement out of the gate, you do not have to answer any medical questions. If later on down the road you want to choose a new Medicare Supplement plan, say 6 months or a year, 2 years, 10 years out, now the insurance company can ask questions that determine your eligibility and your rate. With Medicare Advantage plans, there are never medical questions. There are generally specific periods throughout the year when you can enroll in coverage or switch from one plan to another. So out of the gate, you choose Medicare Advantage. Then October 15th through December 7th, during the annual enrollment period, you have the option to make a change. Let's say that this year you make a change from one plan to another, and January rolls around and you find out that your doctor is no longer in network. If that's the case, you have an open enrollment period, January, February, March of every year, where you can make a one-time change. It's called an open enrollment period. And then, lastly, when it comes to prescription drugs, if you choose the Medicare supplement route, you'll need to purchase a standalone Medicare drug plan. If you choose the Medicare Advantage plan route, you'll need to know if you're choosing a Medicare Advantage plan with prescription drugs or without prescription drugs. Typically, most plans have prescription drug coverage, but sometimes I'll have a client who uses the VA, the Veterans Administration, for their drugs, and they just choose a Medicare Advantage medical benefit only plan. They don't choose one with drug coverage. I do want to be very thoughtful and intentional about saying this next piece. If you don't have a Medicare drug plan or decide not to take it when you're first eligible, there is a penalty later on down the road when you choose to enroll. I had a client last week who was 85 years old. She said she was willing to take the gamble because she didn't need the Medicare drug plan, but now she has multiple myeloma. And I had to explain to her that she's going to have a pretty significant penalty. And she says, well, what other choice do I have at this point? And I said, well, you really don't. So just as a matter of transparency, so there are some unintended consequences to not taking the Medicare drug plan. All right. We're going to do a little pop quiz, and I'm going to ask you to put your answers in chat. When it comes to Medicare annual enrollment period, I want to just get a poll to see where everybody's at. True or false? During the annual enrollment period, I can change from one supplement plan to another without having to answer medical questions. What do you think? Yep, so whoever said false first time only, yep, you're absolutely right. And let me just tell you, you're smarter than the average bear. Whenever I poll, I usually get a 50-50 on this. So we'll keep going. The Medicare, yep, false is the right answer. So the Medicare annual enrollment period is really geared around Medicare Part C and Medicare Part D. If you have a Medicare supplement plan, I'm not saying you can't change it during the annual enrollment period, but as a licensed insurance professional who has had my nose in the books for the last few months getting ready for this, my preference would be for my clients to wait until after we get through busy season where we can spend time with you and do it right. the Medicare annual enrollment period is really geared towards Medicare Part C and Part D. And here's how it all works behind the scenes. Behind the scenes, there's this thing called CMS, the Center for Medicare and Medicaid Services, that sets parameters. They share those parameters with the insurance companies who then design plans within those parameters. The insurance companies take the plans back to CMS and say, may I offer these for enrollment to the general public. And once CMS approves it, then the beneficiaries are able to choose Medicare beneficiaries like you and I on the phone, right? On the webinar. We're able to go out and elect to enroll in one of the plans. Now, think of it kind of like CMS saying to Goldilocks and the Three Bears, the porridge can't be too hot, the porridge can't be too cold, it's got to be just right. And know that insurance companies do have some flexibility within those plan designs, so not all plans are going to look exactly the same when it comes to Medicare Advantage and Medicare prescription drug coverage. Why does the 2026 Medicare new handbook still include some 2025 numbers? That's a great question. Probably because they don't have the 2026 numbers available yet. I would bet that you're referring to the Medicare Part B premium. Is that fair?
Carrie, I just wanted to did you see that other question that says, is the Medicare annual enrollment period the same as the open enrollment period?
Oh boy, great question, Deb. So there are two different enrollment periods. The Medicare annual enrollment period runs from October 15th to December 7th. It's when you can make changes to your Medicare Part D or Part C, Medicare drug or Medicare Advantage plan for coverage to take effect January 1st of 2026 or whatever year we're in, right? The first of the next year. The Medicare open enrollment period is designed for Medicare Advantage only, runs January, February, and March, and allows you to make a one-time change, with that change going into effect the first of the following month. Oh, the full range of deductibles and co-payments, shouldn't they be new in the new handbook? So I'm going to share something very interesting with you, Jeffrey. Yes, they should be. However, they don't release those numbers until the second half of November. And while nobody has ever told me this, I do believe very much that the reason why we're not getting those numbers is because they don't want you to have that information in an election year before the election. So we will be getting Medicare Part B premiums, the Medicare Part B deductibles, the Medicare Part A deductibles and co-insurance, probably on or after November 17th. Real close to that. All right, but here's what we do have. And if you've already read your 2026 Medicare New Guide, you've seen what these changes look like. I've got them on the next slide. But I believe it's important to review what we have currently and go into what we have next. So I'm going to start with stage 1, and this is for a Medicare prescription drug plan design. These are the parameters set forth by Medicare. Stage 1 has a deductible of $590. Stage 2 has an initial coverage level where you pay copays or coinsurance up to $2,000. And stage 3 is catastrophic coverage where you pay nothing. Does anybody know what's missing that used to be a big, big belly ache with Medicare prescription drug coverage? Yep, the donut hole. Very good. Okay, Jeffrey, are you an undercover insurance person? What are you doing here? Are you spying on me? If you are, it's okay. The donut hole is missing. So prior to 2025, I love that you want to keep current. Let me see, is there a heart emoji? I'm going to have to heart that one. That makes my heart happy when people want to be involved in this decision, because there's a lot to this. So the donut hole is not part of the 2025 Medicare Part D plan design because of the Inflation Reduction Act. So the Inflation Reduction Act, eliminated the donut hole and put a $2,000 cap on prescription co-payments and co-insurance in the initial coverage stage. Now I want to pause for just a minute and say a couple things, and hopefully this will make sense to everybody. One is that some insurance companies design plans that have a $0 premium. Some insurance companies design plans that have a $100 premium or more, and there's a lot in between. Some insurance companies design plans that make all prescription drugs subject to the deductible. Some insurance companies design plans that will cover generic drugs or Tier 1 and Tier 2 drugs before the deductible. There's no one-size-fits-all to this. The other thing I want to introduce is this wonderful word called a formulary. And a formulary, this term is extremely important, especially as we look at the $2,000 cap on prescription drug spend in 2025. If a drug is on the plan formulary and you use your Medicare Part D plan at the pharmacy to buy the prescription, that $2,000 maximum out-of-pocket applies. However, if a prescription is not on the formulary, or if you're importing the drug from Canada, or you're using GoodRx or BuzzRx or Single Care, one of the other programs, then those prescriptions you're going around your drug plan to get do not apply to the $2,000 maximum out of pocket. The other thing I want to say is this $2,000 maximum out of pocket doesn't mean that the cost for drugs got any less or the cost for the insurance companies or manufacturing the drugs is any less. What it means is that the consumer's maximum out of pocket was capped at $2,000 under the Inflation Reduction Act. It redirected the costs back to the insurance companies and to the drug manufacturers, which is why at the 11th hour last year, we were told about the premium stabilization demonstration. And that was to do exactly what it sounds like, stabilize the premiums. Jeffrey, I'm super curious, have you heard of that? The premium stabilization demonstration said to the insurance companies, we're going to subsidize you. Good, you have. So we're going to subsidize you to keep the premiums stable while we put this limit on the out-of-pocket cost and figure out how the dollars and cents are going to shake out. All right, so let's look at 2026 Medicare prescription drug plans now. And can anybody guess which direction do you think the deductible went? Do you think the deductible went up, down, or stayed the same? And before I hit enter, I'm going to see if anybody comments. Deb, you're a realist, aren't you? Deb says always up. Yep. So Deb, you're right. We'll go into the 2026. You'll see the deductible went up to $615. The initial coverage stage went up to $2,100. And if anybody is enrolled in smoothing, that will continue in 2026. Does everybody know what smoothing is? Or does anybody know what smoothing is? I bet Jeffrey does. So I had a client, I presented this information at my client appreciation events, and I had a client say, isn't smoothing like Botox? So I'm now referring to this as the Botox of Medicare Part D out-of-pocket costs. And bottom line is, the smoothing is when it's also called M3P or MPPP, where if you have a lot of out-of-pocket costs with your Medicare Part D plan, you can smooth the costs over a 12 or 11 month period instead of having a big deductible and initial coverage stage expenses. So if you have a $1,200 spend, it'll essentially divide that up over 11 or 12 months. How the math actually maps or works out is up to the insurance company, and it's based on some really important behind the scenes factors. So here's the scoop. You want to look at your drug plan every year, whether or not you're on the Blue Choice plan and it's going away, or you're on another standalone Medicare Part D plan. You definitely want to take a look at your 2026 options, because every year formularies change, preferred pharmacies change, plans can be discontinued, such as the case with the Blue Cross plan I've been mentioning. And if I'm beating a dead horse, it's just because it's so important. Sometimes you can be crosswalked over from one plan to another based on CMS approval, but they don't do it based on cost. They do it based on how the formulary works. So just be thoughtful about that. Don't think, oh, I'm not on any medications, or my medications haven't changed, I don't need to look at this. I would say, 5 minutes of review can save you, 5 hours of headache in the upcoming year. The other thing I want to say is sometimes there's new plans available. That won't be the case so much this year. We're actually having some consolidation. So last year there were, in Lake County, I'm talking specific to the area we're in here in Lake County, there were 21 Medicare Part D standalone plan options. This year there were 15, and I think now we've got 12 or 13, something like that, but definitely not as many as we've had in previous years, but you definitely want to shop this every year. All right, let's get into Medicare Advantage, Medicare Part C, and know that as I'm sharing this with you, I'm not really speaking to any specific carrier, but rather trends that I'm seeing overall. I am licensed in a couple states, so I've, again, created this presentation with my clients in mind and looking across the board what's happening, but it's also very indicative of what's coming for 2026 plans in our market here in Illinois, Northern Illinois. Again, not every insurance company is doing these things. Some are doing it more than others, but here's what you can expect. You can expect some carriers to increase the maximum out of pocket. We're expecting some network changes, just as a matter of transparency. We've already been informed that Endeavor Health, the hospital formerly known as North Shore, is no longer going to be accepting Aetna Medicare Advantage plans, nor Blue Cross Blue Shield Medicare Advantage plans. And I like to jokingly say this doesn't mean they're never, ever, ever getting back together. It just means for right now, they're taking a break. It could be 1 year, it could be more, it could be less than a year. They might change their mind next year. When this happens, it's super important to note that this could affect indirectly what you're being told about all of your insurance. And I just want to be very specific to say Medicare Advantage is a certain product within a Medicare market. The same rules don't apply to Medicare supplement plans. We're seeing some Medicare Advantage plans add deductibles into their prescription drug coverage for drugs in tiers 3 and above. We're seeing reduction in some supplemental benefits. We have a client who this year has called us repeatedly because he had a Medicare Advantage plan last year with a $5,000 dental deductible. It went down to $3,000 this year. It'll adjust again next year, up or down, or however they decide based on actuarial value. But when those supplemental benefits decrease, it's never fun to find that out in January or February or March. It's better to look at your annual notice of changes document and find that out now. The other thing is formulary changes. We're back to that wonderful formulary word. I do want to say that anybody who's on Xarelto, there is a new generic available. When I've looked that up on Medicare.gov for 2026, it's showing it at Tier 3. So even though it's being called a generic, and when you go out to Medicare.gov, it says there's a generic available, it's still a very expensive drug, and it's being subject to the deductible. And the last thing I want to talk about, which is not something that many people are talking about, is indirect steering by insurance companies by making certain plans non-commissionable. So without getting on a soapbox for too long, I do want to share that I'm most often compensated by an insurance company paying a commission to me for somebody enrolling in coverage through my agency. There are some insurance companies who have made the decision not to pay a commission to somebody who is external. So what that means is that if you call them, they have an internal sales agent who works for them who will enroll you in coverage and get compensation. However, if I as a broker am assisting you, and a broker, by the way, means that I work with different insurance companies, I have contracts with them, and your best interest is my best interest. If I enroll you in coverage with one of those plans, they don't pay me any commission. And know that I'm not wanting to make, this isn't about me getting paid or whatnot, this is about you, and I want to make it clear that when they don't pay an external sales force or a broker a commission, it's because they really don't want people enrolling in that plan, but they've already filed it with CMS and they have to take you if you enroll direct. So just a thing to be aware of. You do want to shop your Medicare Advantage plan every year. Oh, looks like so it looks like a question came up. In my experience, what's the main reason for insureds determining that a Medicare Advantage plan is not for them after being covered? So the way I'm interpreting that is somebody chose a Medicare Advantage plan and then they decided that they no longer wanted it. Probably the primary reason is due to skilled nursing. There can be some limitations when it comes to access to skilled nursing facilities. But I've also had clients tell me, I don't want to have to wait 2 weeks for the insurance company to approve my MRI or my CT scan. With original Medicare, I didn't have that in a supplement. But it's going to be 6 one, half dozen the other, right? You're either going to pay on the front end or pay on the back end. If you're paying on the front end with a supplement, you don't have all the rules and you have very low out-of-pocket costs. But on the back end, with Medicare Advantage, you might not have a monthly premium and pay as you go, but you get all the extra benefits. So it's a matter of really evaluating your priorities and what matters most to you in this journey. When it comes to your Medicare Advantage plan, you absolutely should review it every year. Plan premiums can change, provider networks can change, as I mentioned with Endeavor. Drug formularies can change and out-of-pocket maximums. Even the extra benefits, the dental, vision, hearing, and wellness perks. I'm going to talk about 2 things that aren't on the slide just in case we have anybody who's on Medicare and Medicaid. If we do, it's important to know that MMAI in Illinois, Medicare and Medicaid Alignment Initiative, is going away, and people will generally be transitioned over to the insurance company that offers whatever dual special needs plan, Medicare Advantage plan for that population. Excuse me, the other thing I want to say is that if your Medicare Advantage plan decides to exit the market altogether, that does create a special enrollment period for you to go back to a Medicare supplement plan and not have to answer medical questions. So, that's something to be aware of. So, okay, we got another question asking, am I in favor of long-term care insurance programs offered by carriers? I'm going to come back to that one if you don't mind, just to get through the Medicare piece, and then I'm happy to answer that. So, and I apologize, I forgot to update this to say for 2026. So when you read 2025, know that I meant to say 2026. Here's what your position should be is my current coverage meeting my needs? Do I already know that my doctor is not going to be in network next year? Is my current coverage limiting access to providers and services? If it is, it might be time for a change. Medicare Advantage has a one year, 12-month trial right to see if it's right for you. It doesn't apply in every situation, but you can definitely inquire if you're on a Medicare Advantage plan or if you're looking at Medicare Advantage as an option. Know your rights and know the trial right. We do have one Medicare supplemental plan that does not ask medical questions. This is true in Illinois only, and you could get coverage as soon as 1/1/26. Again, I forgot to update the numbers on this slide. Watch for your annual notice of changes, and the annual enrollment period is October 15th to December 7th. I'm going to talk about some additional changes that are coming to a theater near you, or coming to Medicare, sort of. This one, there was actually a stay just put on this a couple weeks ago. But there was an introduction legislatively of this program called the WISER model, standing for Wasteful and Inappropriate Service Reduction. This applies to original Medicare, which historically has not had prior authorizations. And this model intended to reduce fraud, waste, and abuse by implementing some technology and adding a prior authorization process to a handful of services in a handful of states for a 5-year period. I do again want to emphasize that there has been a stay put on this. So while this was introduced, it is not moving forward at this time. Also, Illinois was not affected, but I do happen to have clients in some of these other states. So I want my clients in those states to know, so I put this together for them. But also, when Medicare is making changes, I want everybody to know. It's not like they're sending out an announcement. So let's talk about those procedures that we're going to be affected. And again, the effect was prior authorization would be conducted in those selected states for the following services. Prior authorization, by the way, simply means that the insurance company has to ask the doctor to please prove medical necessity. And these were things on electrical nerve stimulators, sacral nerve stimulators, phrenic nerve stimulators, deep brain, vagus nerve stimulation, right? What I want to point out is a couple, obviously the number of stimulators, but also the epidural steroid injections for pain management. I want to point out the incontinence control devices. What this says to me is that there was a lot of fraud, waste, and abuse, or potential for that. There were a lot more procedures being ordered than in recent years than in past years. So Medicare said, well, we'd like to then, to maintain the solvency of our program, we'd like to implement a prior authorization rule for that. Yep, I'll come back to Medicare Supplement, Medicare Advantage. Give me just a minute. So the other big change for 2026 was this declination or the current administration declining to finalize the coverage of GLP-1s, but I want to be very intentional that means for weight loss only. So GLP-1s, and I want to see if I can get this to pop up real quick. No, it's not gonna. Okay, there should be another. Here it is. Okay. So under the prior administration, there was a rule about covering, or there was a proposed rule about covering GLP-1s for weight loss. The current administration declined to finalize that rule, and right now, as of April 2025, most state Medicaid programs and Medicare Part D will not cover GLP-1s that are prescribed solely, which means only, for weight loss. Coverage typically is limited to conditions such as type 2 diabetes, cardiovascular disease, kidney disease, or obstructive sleep apnea. So there had to be another underlying medical condition in order for that to be covered. Now, I'm a big fan of being an equal opportunity offender, and I'm just gonna, because I talked about some administrative or presidential decisions, I want to go back to the first Trump administration in introducing the price cap for insulin. And when Biden came in, that administration came in, they said they undid what Trump had done and they redid it and took credit for it. And so now Trump is undoing this, and he's going to be, it looks like, all signs point to introducing something else related to GLP-1s for weight loss. I know the Trump RX has been hitting the news, and the, I forget, America First, greatest country party, something or other. I honestly can't stay on top of all of the changes. But most favored nation, sorry. Took me a minute. So don't be surprised if you don't see something coming with regards to that. Next, I want to talk about Cigna being rebranded to HealthSpring, and HealthSpring being acquired by Healthcare Service Corporation. The short version of this page is that Healthcare Service Corporation currently is a parent company for Blue Cross Blue Shield of Illinois, New Mexico, Oklahoma, Texas, and Montana. They wanted to have a national footprint, I think to compete with United Healthcare and their Medicare supplement plan, because they've got they've got a brand recognition across all of the United States, whereas Blue Cross is franchised and operates under a different name in each state. So I think this is HCSC's attempt to have a national brand. And with that, I'm going to say thank you, and I'm going to go back to some of these questions and answer them.